Good afternoon and welcome to Facebook Live with Holy Cross Health. My name is Brenton Andrasic, Manager of Physician Alignment and Business Development at Holy Cross Health, and we're coming to you live from Holy Cross Hospital in Silver Spring, Maryland. Before we begin, I'd like to call your attention to a few ground rules that you'll see in the comments section. We encourage you to participate, but please keep any questions and comments general. We won't be discussing anyone's specific health situation in this public forum. If we can't get to every question today, we'll provide additional feedback through Holy Cross Health's blog, or we can connect with you one-on-one by phone or online. So we're talking about colorectal health today, and I want to acknowledge that this is not an easy topic to discuss. Colorectal health can be a sensitive issue, but today we promise to have a frank, open, and honest discussion about a very serious topic. So for those of you joining us today on Facebook, we thank you for being here and for taking an active role in your health. And we at Holy Cross are happy to be your partner in your health journey. Today we're here with Dr. Bradley Bennett, Medical Director of Colorectal Surgery at Holy Cross Health, and Dr. Matthew Skanke, a member of Holy Cross Health Partners. Dr. Bennett and Dr. Skanke are both practicing colorectal surgeons and integral members of the colorectal surgery team at Holy Cross Health. And I'd like to point out that we're all following CDC guidelines and are adequately distanced here in the room today. So let's start by setting the stage for the scope of this issue. According to estimates from the American Cancer Society, the U.S. is expected to see over 104,000 new cases of colon cancer and over 45,000 new cases of rectal cancer in 2021 alone. That makes colorectal cancer combined the third most common cancer diagnosis, and it's the second most common cause of deaths from cancer. So Dr. Bennett, I'd like to start with you. One of the best tools we have for combating colon cancer is early screening. Can you tell us a little bit about the importance of screening?
I think colonoscopy still is our best tool. I think the key thing to understand with colorectal cancer is that prevention is the most important device we have for treatment of this disease. And the best thing we need to do is use screening techniques that actually prevent people from getting colon cancer. We do that with colonoscopy, but not only examining the colon, but getting out polyps from the colon, which are precursors to malignancy. Other tests you hear about will tell you about early diagnosis of colorectal cancer. Although that's a good thing, prevention is a better thing. And that's why colonoscopy is still the best tool we have.
Dr. Skanke, what age should people start thinking about getting screened, and what are some of the risk factors that people should think about that impact the recommendation for screening?
So for average risk individuals, the current recommendation is age 45, assuming no family history of any kind of colorectal cancer or colorectal polyps. When that comes into an issue, it's usually 10 years before the earliest diagnosis of cancer or polyps, or age 40, whichever is earlier. So it's really the beginning screening bumped up a little bit. Now, there is some data to suggest that certain demographics are at higher risk, but we don't have enough data to make to correspond our recommendations with what is done at the federal level. So the current recommendation is 45. Symptoms that people should keep an eye out for correspond with the three main symptoms of new diagnosis of colon and rectal cancer, which would be abdominal pain, which is usually vague, can sometimes be crampy. And again, that's a very nebulous symptom. You also have change in bowel function or change in stool caliber. The textbook would describe a pencil stool, but really a change in any kind of change in bowel function corresponding with the other symptoms, especially with rectal bleeding, should always warrant a trip to see either your gastroenterologist or your colorectal surgeon or your primary care doctor to start yourself on the pathway to figure out what the symptomatology is suggesting. Again, I realize those are very nebulous symptoms, and they could be from a range of things, ranging from benign disease to malignant disease, but we always urge the utmost caution when it comes to those three symptoms. And since Dr. Bennett said colonoscopies are exceedingly effective at determining early risks and early at-risk polyps or even early diagnosis of colon cancers, we always are very quick to recommend a colonoscopy when patients will show up in the right age bracket with the symptoms.
So, I'd just like to point out that we did promise a frank and open conversation today. As you hear, we're already well on that track, talking about changes in stool. So, welcome to Facebook Live with Holy Cross Health. I've heard that guidelines have changed recently around who can get colonoscopies or who's recommended to get colonoscopies in certain age ranges. So could you talk a little bit more about some of those guideline changes and try to clear up some of the confusion that might exist?
Well, a lot of it is coming from the fact that we're able to look at larger data sets every day. Holy Cross in particular is very good about checking their data, accumulating data, and then evaluating who's at risk for certain diseases. But when you look at a national level, you'll see that patients are showing up at younger ages with more advanced cancers. Historically, colon and rectal cancer was a disease of individuals in their 7th decade or in their 60s. But with our improvement in detection technology and the greater acceptance of colonoscopy, those individuals are being captured or prevented by diagnosing precancerous polyps before they have a chance to continue their journey. What that means is that now it's the younger ages of individuals are being screened and diagnosed more aggressively, and we're finding more pathology the more we screen, which makes sense. But at the same time, we have to take a very sobering look on what the data shows. And the data has shown that we need to screen individuals earlier because people are showing up with advanced disease. One of the very common ones, or one of the popular one, pop culture one that's come up recently is Chadwick Boseman's diagnosis with advanced colon cancer. He was in his 40s, and that was advanced disease. So we know that polyps will take between 3 and 8 years to make their genetic trip with their mutations down the road from benign colonic mucosa to advanced adenocarcinoma. So we're very aggressive in terms of screening people at an early age. It is not done at a drop of a hat, but if you come to a colorectal doctor's office with abdominal pain, change in stools, or rectal bleeding, you will have the colonoscopy talk.
So this is the real shit. I think certainly when I was younger, we would ignore the bleeding in 30-year-olds and assumed it was always hemorrhoids. I think, and previously that was probably the case. But now there's a downward trend in the age group of the patients we're seeing. And we're being much more careful with the 30-year-olds than we used to be. Well, what would be the source of their bleeding and the screening at a much earlier age than we would have done maybe 20 years ago.
So we've talked about colonoscopy, the main tool that we have in this fight. Let's talk a little bit more about the colonoscopy process. Dr. Bennett, could you just walk me through what a patient can expect, and starting with the bowel prep and then going forward from there?
Well, for most people who've talked to other individuals who've had colonoscopy, you recognize that the bowel prep is many times the biggest part of the procedure. We have altered how we give those bowel preps in the last few years by splitting the preparation from part the night before and part the morning of the examinations. It's made it a much more comfortable process. Many times patients won't have any memory of having a colonoscopy at all, so that the only memory of the procedure will be the prep, and we try to make that as comfortable as we can for the patient.
Does it hurt at all?
No, it's a bit more of a nuisance. Anything that the colonoscope actually is a tube about the size of your finger, but the camera part of it, the part we're looking through, is 1 to 2 millimeters in size. So it's very small. It doesn't take a lot of stool to obscure its view. So we need to do a pretty aggressive clean out so we get a good, clear examination of the colon, so we don't keep down the chances of missing things during the day.
So we've talked a lot about colonoscopy so far, but there are some other tools that are available. Dr. Stanton, could you just talk a little bit about some of the other types of screening tools that a patient might expect, say they're going to the primary care or to another physician? What are some other things that they might be on the lookout for if they're screening?
Sure. So some of the ones that most people will be most familiar with the fecal called blood card. That looks for breakdown in blood products, essentially to detect microscopic rectal bleeding in the stool. It's effective at detecting things, but I think the key factor here is that all of these detection tools that are not a colonoscopy will ultimately lead to a colonoscopy if the result is anything but completely negative. So ambiguous results lead to a colonoscopy. Positive results lead to a colonoscopy. Even if you have a positive result and a negative result afterwards, it still leads to a colonoscopy. You can kind of get where I'm going with this, and that's why the colonoscopy has always been the gold standard. If you look at the sensitivity of the colonoscopy in terms of detecting cancers, it's very good. It's over 90%. And some of these other adjuncts are also good at detecting cancers. But as Dr. Bennett pointed out, our goal is for cancer prevention by detecting polyps before they become aggressive cancer. And these other non-colonoscopy things, with the exception of a flexible sigmoidoscopy, which is a limited colonoscopy, are all not able to detect things that are smaller. And as their sensitivity goes down as the polyp gets smaller. Now, with a colonoscopy, you can easily detect 5 millimeter or smaller polyps. Your ability to do that is obviously less than if you have a 2 centimeter polyp, just because you can see more with a 2 centimeter polyp. The general gist is that all screening tests lead to a colonoscopy because it is the best tool to both diagnose and treat these early stage polyps and then cancer as well.
And the key really is to find the small polyps and get them out before they would be able to be picked up by all of the other stool screening technology that we have presently available.
So some people might have heard of Cologuard. You see a lot of commercials for this now. In fact, I think we'll just follow up with you on that question. What is that? How does it work? What can people expect from it?
So it's a more refined version of the fecal called blood test. Cologuard is looking more for genetic mutations in cells that are filtering through the stool. I believe it's looking for APC, P53, and KRAS gene mutations, which are the 3 primary mutations for polyps mutating from benign colonic mucosa to polyp to advanced polyp to cancer. If any of those are present, that obviously prompts a colonoscopy. Now, these tests are effective if you have no access to a colonoscopy. So if you are unable to get one for medical reasons, if you are unable to get one, they are better than nothing. But the best answer and the best test and the most reliable test at preventing colon cancer is the colonoscopy.
So we had an opportunity for some people to submit questions when they registered for this event in advance. And so I think this may be a good time for one of them. One of our viewers asked, at what age should you stop getting screened for colon cancer? Dr. Bennett, I'll put that one to you.
Generally, the rule is now 80 years of age. And I think there are an occasional exception to that rule. Certainly, we're seeing people living into their 90s very commonly. So we have some very healthy 80-year-olds who've had history of polyps, where we may not we may consider doing an extra exam in their 80s. As Dr. Skanke mentioned, it's a 5 to 8 year process. And so if you stop getting colonoscopies when you have a history of polyps, and let's assume you're in excellent health, you may live well into your 90s, which will give you enough years to go on and develop a cancer in your later years. And that's one of the things we really don't like to see. We don't like to be boxed into the situation of doing a very complex operation for a cancer when people's health is declined in their 90s, when we know that there's a possibility of prevention. So I think generally the rule is 80, but there are some exceptions to the rule.
We had another question from a viewer that I think might fit here. Well, we sort of wrap up our discussion about screening. And Dr. Bennett, I put this one to you as well. Someone asked, do I need a referral to get a colorectal screening? And I'll add to that, does insurance typically cover it? And what does it cost to the patient typically?
No, well, a lot of this varies on the type of insurance that you carry and the actual plan that you have. There can be deductibles and co-insurances with any type of insurance plan that you might have. So if you're going to have the exam, the best thing to do is to contact your insurance company to see what your specific plan allows. Most of the plans, which are in the screening age group, allow coming directly to the physician's office to arrange an examination. There are some exceptions, but generally you can come in directly to see someone to have such an exam performed.
Right. So I'd like to take a moment to move on from the screening process now to let's talk a little bit about what happens after screening. So we talked, let's go on to diagnosis and to staging if needed. So Dr. Skanke, you talked a little bit about this before, so I'll just ask you to reiterate and elaborate if you want. What are some of the symptoms that people should be on the lookout for that might cause them to seek out your services or another providers
Sure.
services in a similar area?
The main symptoms are change in stool caliber, rectal bleeding, and nebulous abdominal pain or crampy abdominal pain. All of those are suggesting that there is some kind of space-occupying lesion within the colon. The rectal bleeding comes from just the shedding of dividing cells that are much more friable. So when stool passes over a cancer, it can irritate the area and lead to debriding of the area, which leads to blood and cells coming across. And I think just to clarify something before, the Cologuard thing is more for a blood test than specific for human, whereas the fecal blood is more for any kind of globin moiety. The gene mutations I was talking about was more for the other tests that are there as well. They can all be done in concert for better specificity, but just to make that clear. In terms of the symptoms, like I mentioned, the abdominal pain, the rectal bleeding, and the change in stool caliber are the big ones. But they can be from many different disease processes, which is why we always recommend colonoscopy to start.
And your primary care doctor may have picked up something in a general physical examination that might lead you to do this type of screening. Very commonly, your blood count's checked as part of your routine physical examination, and they may discover an anemia. They may discover particularly the kind of anemia which is consistent with blood loss. And that's another common source where we'll have patients sent to us for evaluation.
This might be another good place for a pre-registration question that we had. Someone asked, when I go to the bathroom, I see burgundy mucus on toilet paper. Should I be concerned? Dr. Stanke, we can continue on your conversation there.
My answer to that would be yes. Burgundy mucus is not something we like to hear when we hear it described when we ask people what their bowel movements look like. It can be from a number of things. It could be from something benign like hemorrhoids. It could also be something malignant like a rectal cancer that's low down. It really depends, but if that is a symptom that is happening, then it should be evaluated at least by a primary care doctor to start, and then it should be progressed to see a gastroenterological specialist, whether that's a gastroenterologist or a colorectal surgeon for a diagnosis.
So, Dr. Bennett, let's say that an issue has been discovered, whether it's through routine screening or a patient came to you or to the PCP or to a gastroenterologist with symptoms that we just described, and we found something that's concerning for cancer. Can you talk a little bit about the staging process or what that means and what sorts of tools and technologies we have available to us at Holy Cross to be able to adequately stage and diagnose cancers?
I always like to describe this as somebody putting together a puzzle. First question in the puzzle is, what is the source of this, for example, this blood mucus was just mentioned by this last patient. And that may lead to a colonoscopy that discovers a cancer in the colon. And that's the first piece of the puzzle, is the source. Then we need to find out a lot more about this cancer. Cancers have two characteristics that we need to be evaluated. One is they can grow into things locally. If it's a cancer of the rectum, we may do a special X-ray of around the rectum to see whether that's occurred. The next thing that cancers can do is that after they grow into things, they can also travel. They can get into various parts of our blood system and go to other organs. They can go to lymph nodes around where the cancer started, or they can travel to distant sites like the lung and the liver. So another set of X-rays we would probably do as part of this initial evaluation, getting more pieces of the puzzle, is to do CT scans. We do that commonly in the abdominal cavity and the chest to look for any spread. So all of these things gain information, and the more information we have, the better we are at piecing together a treatment plan.
So we have a viewer question here, and we'll open this up to the forum to see whoever wants to take it. But it sounds like someone may be having an issue getting a colonoscopy because of what's described as a twisted colon. Could you just maybe describe how that might happen and what are some potential avenues that someone with that condition might be able to take to get screened?
Well, twisted colon is, there could be a couple things. that it could be. The thing that we are always worried about the most would be a volvulus, which would be considered a surgical emergency, which would probably be crampy pain that is intermittent or transient with complete obstipation or the inability to pass gas or stool. Now, if that is truly what the viewer's question is regarding, that's something that needs to be addressed at a hospital. If by a twisting colon, someone is talking about a very tortuous colon, that's also possible. Everybody's anatomy is different. There are certain landmarks in the colonoscopy where the colon is harder to traverse just due to the anatomy. For tall people, sometimes getting around the left side of the colon where the spleen is can be difficult, or around the right side of the colon where the liver is can be difficult. Sometimes in women, getting through the sigmoid colon can be difficult, especially in women who have had prior pelvic surgery like a hysterectomy. So I would say to the individual who's asking this question, if you're also having abdominal pain with this, you should seek medical care more emergently. If it is truly something that you've never had abdominal pain and you were just told by your gastroenterologist or your colorectal surgeon that you have a tortuous colon or twisty colon, that is something that you didn't do to yourself. It just makes the colonoscopy that much harder. Now, there are certain situations where the entire colon can't be evaluated on colonoscopy despite multiple attempts or multiple different endoscopists. And in that certain case, and again, those cases are rare, then we have to discuss amongst ourselves as colorectal surgeons what's in the best interest for the patient in terms of keeping the portion of the colon that can't be surveyed cancer-free. And in that case, sometimes a resection is needed. But again, without knowing more about this particular situation, it's hard to render judgment.
But you also have to remember what this twisty colon most of the time, or the tortuous colon. I think and some people get the impression this is a disease that has to be fixed, and it's not. It's just a variation in the way your anatomy is arranged, making colonoscopy difficult. It doesn't affect how well the colon works. It doesn't prevent it from emptying. It's just one of those natural variations that can be related to how you were built or previous surgery, possibly. So some patients like this will end up getting other evaluations of the colon instead of a virtual colonoscopy or old-fashioned barium animus. And the last choice on the list would actually go back and do the Cologuard test. But again, the Cologuard test is our least favorite test because even the virtual colonoscopy would identify whether people make polyps. And again, that's the whole purpose of all these exams, trying not to wait till they have the cancers. Sometimes the colon needs to be looked at in different ways.
So hopefully that's helpful to our viewers. And we've covered a lot of ground so far. We've talked about prevention. We've talked about screening. We've talked about diagnosis and staging. And I want to spend some of the remaining time we have here talking about treatment. We touched on it a little bit, but let's say that a patient has come to you and we've identified a problem and we've determined the stage of the disease. What are some of the things we can do about it? What are some of the treatments for colon cancer specifically available at Holy Cross? Dr. Bennett, as our medical director, I will throw that one to you.
Didn't answer your question about staging, so probably ought to go back to what we want to find on those staging tests, the CT scans, maybe MRI. We don't want to see any signs of distal spread from the original cancer. That can radically change how the tumor is treated. So the assumption we're going to make is that you've gone through all of these tests, and the tests show that looks like the cancer is localized to a spot in your lower digestive tract, the colon and rectum. Colon and rectal diseases are treated differently. So we'll start out with the one that's a little more simple, which is colon cancer. Colon cancer is primarily treated with surgery alone. That reason we do the surgery first is that we very uncommon to leave cancer cells behind at the spot where cancer occurred when it located in the colon. So there's what we would be scheduling these days is a robotic assisted resection. We've moved in the 1990s from large incisional surgery to small incision surgery. That was called laparoscopic surgery at that time. it had significant disadvantages compared to open surgery because the surgery essentially was done with one eye closed with two Chinese chopsticks, great instruments with quite limited mobility. We've moved on since 2010 to more sophisticated technology, which has returned our operations more like what we used to do before the laparoscopic era. We now can see with both eyes. We have wristed instruments, and that's the robotic platform. And the robotic platform is what we use now to do most of our colon sections. So rectal cancer.
You gave me the easy one. So rectal cancer is slightly more nuanced because you're not operating in the abdomen proper. You're operating in within the confines of the bone and pelvis. It differs for every individual. Some people have a narrow pelvis, some people have a wide pelvis. Some people have a deep pelvis, some people have a shallow pelvis. Regardless, there's still very important structures that run down the sidewalls of the pelvis. Both blood vessels supplying the parts of the pelvis, the urine-carrying structures or ureters, and the nerves that focus on erectile function, dysfunction, bladder control, sympathetic, parasympathetic nerves, sexual function, etc. So with all of those things running near the area of disease, the surgery becomes much harder and much more technically demanding, which is where the robot is very helpful. What Dr. Bennett mentioned about being able to operate with two eyes is very important, but you also get right up next to the tissue. Whereas if you're operating through a big incision, by definition, you're 1 to 2 feet away from where your eyes are, at least from where the tissue plane is, whereas the robot, you're centimeters away. So you're able to see tissue planes you'd not normally be able to see without having to sacrifice the mobility of your wrists, which is what we have to do with laparoscopy. With rectal cancer, and also because it's a confined area, and as Dr. Bennett said, it may be harder to get all of the tumor cells at a microscopic level out of the area. These patients usually will undergo pre-surgical chemotherapy and radiation. We know that for individuals who have locally advanced disease that is greater than T2, or disease that is starting to encroach into the mesorectal fatum, which is around the rectum, that radiation and chemotherapy is very helpful at reducing local recurrence, in addition to the surgical technique of a total mesorectal excision. What that means for a patient who's diagnosed with low rectal cancer is that they will probably also speak to an oncologist before their surgery and undergo 1 to 2 months of chemotherapy and radiation, after which they will repeat their images, pelvic MRI, CAT scan of chest, abdomen, pelvis, maybe an endorectal ultrasound, maybe a repeat colonoscopy, prior to talking to the surgeon again about scheduling their surgery 4 to 8 weeks after completing their chemotherapy and radiation. Now, we know that the radiation continues to work after it's done for about 6 to 8 weeks. Different studies have shown benefits of longer course radiation, shorter course radiation. That's a conversation to have with your colorectal surgeon for your particular case. There are benefits to both. But the gold standard in America at the time is for the pre-treatment for around 2 months prior to surgery.
Important. That's where coordination of care is really the key for the management of rectal cancer. So, as we just talked about, colon cancer, you move almost there's any signs of spread. You move directly to the surgeon if there's any abnormalities that are concerning after the surgery. You may then need to see an oncologist. But the coordination of care prior to surgical intervention is not such a key issue. It certainly is with rectal cancer. Dr. Skanke, as mentioned, you may need to see an oncologist. Prior to your surgery, you may need to see a radiation therapist. Taking all the information that you got from the pathologist and the regular radiologist who did the scans, all of these things need to be put together in a coordinated fashion. Holy Cross has now dedicated itself to opening and proceeding to its own cancer center, where such coordination is easier to carry out. I think that if you put everybody in the same building, it's easy to talk to the radiation therapist, pathologist, oncologist, and it's much easier to have your coordinated cancer evaluations, these cancer conferences to work out what's the best program for each individual. That's where we're going in Holy Cross Hospital.
So, Dr. Bennett, I'm glad that you made that transition. So we can maybe just talk a little bit about that as we're coming up near the end of our time. Thinking about the Holy Cross colorectal program as a whole, we already heard about some of the things that make it an outstanding program. But as our medical director, what else would you say makes it unique? And also, what can patients expect from our program at Holy Cross?
The thing about this program is it's growing. We just brought it over the last few years. We brought in a colorectal surgeon from who's trained up in the New Jersey area. Dr. McCool. We've now brought in Dr. Skank, who's trained in Cleveland Clinic programs. We're expanding this program and making it one of the 3 top centers for this type of treatment in the state. We've been recognized as that for years, and I think we want to continue to emphasize that program at Holy Cross Hospital system, both hospitals, one in Germantown and one in Silver Spring.
So, Dr. Skanky, Dr. Bennett just mentioned you're joining our team fairly recently. If someone is interested in making an appointment with you, how quickly can patients get in to see you?
As soon as they're available to. We have availability between the 3 individuals in the colorectal group at Holy Cross to see people on the same day. And we always prioritize patients who have concerns or referrals for colon and rectal cancer. That is the utmost important to us. Now, if you also have a hemorrhoid or an anal abscess, that's equally as important to us. And we're happy to help with that. But I would be lying to say that colorectal cancer, anal cancer patients don't get priority when it comes to appointments. They do, because that is very time sensitive and very emotionally charging for the patient when they're diagnosed with that. And it's our job in part to take care of them physically and mechanically, but in part to take care of them emotionally and intellectually as well. So if you called up with the same one of these diagnoses, you could be seen the same day. It's not uncommon. You could have a colonoscopy done the next week. It's not uncommon. So we can get things moving very quickly with the resources that Holy Cross has devoted to us in really just in showing that they have a huge priority for colon and rectal cancer treatment.
And related to that, we're coming towards the end of our time, and so I wanted to make sure we get in some questions from viewers here. We did have one related to the idea that it's not just cancer that we treat in the program, and also the idea of urgency. Someone asked, is anal fistula life-threatening? I will pose that to whoever wants to answer.
Oh, if I had one, I would think it was. This is one of those benign conditions that, first of all, causes a lot of confusion with patients to what's going on. So I think the first thing is for the patients to make sure that's what's going on in that particular patient, that there is not something more serious that's behind the fistula. Then all fistulas have to be fixed. They're not only a nuisance, but they're painful. They unless they're fixed, they cause recurring abscesses around the anus, which are painful, and they can be very destructive over time. So it's another one of those things we commonly treat, and it is something that is we don't recommend patients live with. They need to be fixed or repaired.
Mm-hmm. We also had a recordings question that came in as well. How do you treat bleeding hemorrhoids while on blood thinners?
That can be a little tricky. It depends what the blood thinner is for, whether it can be stopped, how long it can be stopped for, how much bleeding is from the hemorrhoids. But the traditional hemorrhoid surgery was excision of hemorrhoids. We've now kind of evolved. We have other ways of treating hemorrhoidal diseases that involve just suture ligation, photodynamic therapy, infrared coagulation, and also injection sclerotherapy. So we have many ways to treat hemorrhoids. Obviously, the largest and most aggressive is the excisional hemorrhoidectomy, but that puts you at the highest risk for bleeding. So it would really be a tailored approach based on the size of your hemorrhoids, their location, and the reason for being on blood thinner.
And last question, before we wrap up, where can patients expect to receive treatment for some of the things that we discussed today?
A lot of the evaluations we do are done in the office. Some of the newer technology we brought in the office is the three-dimensional ultrasound test that we're doing to evaluate rectal cancers and to follow people who've had surgery in that area. The more minor conditions like the hemorrhoids we talked about, many times they are treated in the office. As we get the more complex problems done in the hospital, they are certainly done. Our cancer surgeries are done in both of the Holy Cross Hospital, Silver Spring, and Germantown. We have the most advanced robotic platforms in the county. We're the only hospital that have the XI robot, which were really designed for this type of surgical intervention. So either of the two hospitals, the Holy Cross Hospital system in the county.
Well, we're about out of time, so thank you so much to Dr. Skanke and Dr. Bennett for joining us today and answering some of our questions. I learned a lot. Hopefully everyone watching learned a lot as well. Thank you to those of you who tuned in. If we didn't get to your question, we're planning to provide additional information through Holy Cross Health's blog, or we can connect with you one-on-one through our colorectal cancer program channels, whether it's online or on the phone. So you can connect with us to learn more about our colorectal cancer program. You can schedule an appointment or seek a second opinion by calling 301-557-1426. And for more information about cancer care at Holy Cross Health, you can always call the Holy Cross Hope Line at 855-424-4673. And of course, at any time, you can visit our website, holycrosshealth.org/colorectal-cancer. Thank you for joining us today on Facebook Live with Holy Cross Health, and we hope to see you again soon.